Hello everyone. So today let's talk about abnormal scars. Scar formation is a normal part of wound healing, and there are three main types of abnormal scars: atrophic scar, hypertrophic scar and keloid. First, let's start with atrophic scar. In atrophic scar, there is thinning of the epidermis and dermis such that the scar appears flat, pale, stretched and depressed. So the peculiar example of atrophic scar is acne. After the inflammatory lesions, they heal. They heal by scar formation, which is usually depressed and atrophic. Now let's talk about hypertrophic scar. So hypertrophic scar, it is the excessive formation of scar tissue that does not extend beyond the boundaries of the original wound or incision. So in this diagram, so this is a normal linear scar over a linear wound. And in this diagram, we can see that the scar, it has hypertrophied, but it does not extend beyond the boundaries of the original wound. So this is hypertrophic scar. Whereas in this diagram, we can see that if this is a normal wound, then the scar has extended much beyond the boundaries of the normal wound. So this is keloid. Hypertrophic scar, it can occur anywhere in the body, so there is no peculiar site where it occurs, and it is not genetically predisposed, unlike keloids. And they usually resolve within 6 months spontaneously. Talking about the etiology, it is common in wounds crossing the tension lines of the skin. So if these are the normal tension lines of the skin, and the wound that occurs crossing these tension lines of the skin, then that results in hypertrophic scar. Another etiology is deep dermal burns and in wounds that heal by secondary intention. So what is this? So wounds that have extensive soft tissue loss, they heal quite slowly and they may hypertrophy and may even lead to contracture. So wounds that heal by secondary intention may lead to hypertrophic scar. Talking about the histology, there is excess type 3 collagen and hypervascularity found in hypertrophic scar. And talking about management, pressure therapy is the first line of therapy. So silicone gel sheet is applied as a pressure therapy. Another treatment option is intralesional injection of triamcinolone. So triamcinolone is a steroid. And if these two treatment modalities don't work, then we can even do surgical excision of the scar and closure. Now let's talk about keloid. So keloid, it is the excessive scar tissue formation that extends beyond the boundaries of the original wound or incision. As I have already shown in this diagram, so the scar, it has extended much beyond the boundaries of the original wound. And it continues to grow even after 6 months and may persist for years. And it is usually brownish black or pinkish black in color, and it may be tender, sometimes hyperesthetic, and may lead to itching as well. Now talking about the etiology, it may be genetically predisposed and it's more common in deeply pigmented skin and in females. It occurs due to the defect in collagen maturation and stabilization, and it may be associated with Ehlers-Danlos syndrome and scleroderma. So these are some connective tissue disorders where keloids are common. And in histology, we can see thick, disorganized type 3 collagen and proliferating immature blood vessels and immature fibroblasts. Talking about the site, so the most common sites where keloids occur are over the sternum, upper arm, chest wall and lower part of the neck. So in this figure, in this photo, we can see that there are multiple keloids over the sternum and a keloid over a chest wall. Now talking about management, since keloid have high recurrence rate, about 50%, the management is quite controversial. And the mainstay, the first line of therapy, it is intrakeloidal injection of triamcinolone at regular intervals, once in every 7 to 10 days. And triamcinolone, it is a steroid and it works by reducing the fibroblast proliferation and collagen synthesis which occurs in keloid. And another treatment modality is using methotrexate and vitamin A therapy. Another treatment option is silicone gel sheet application and laser therapy as well. And if all of these don't work, then we should go for surgical excision. So intralesional excision, retaining the scar margin, it is better than just excising. So just excising the keloid, it may lead to high recurrence rate. So we prefer intralesional excision, retaining the scar margins. So radiotherapy after excision can be done, or just radiotherapy alone can also be done. So in radiotherapy, we usually go for external beam radiotherapy or brachytherapy. And after excision, if the defect left is quite large, then we need to go for skin grafting as well. So this was about abnormal scars, especially focusing on hypertrophic scar and keloids. I hope you learned something from this video, and I will see you in the next one. Thank you.